The Concertina effect or accordion effect in WPW syndrome refers to the dynamic beat-to-beat variation in the degree of ventricular pre-excitation visible on a single ECG rhythm strip. On an ECG, this manifests as a QRS complex that sequentially widens and narrows, accompanied by an inversely fluctuating PR interval resembling the expansion and compression of a concertina. The degree of pre-excitation in WPW depends on a race between two parallel electrical routes. The normal AV node is Purkinje system and the accessory pathway or bundle of Kent. The concertina effect occurs due to shifting autonomic tone, continuously altering the conduction velocity and refractoriness of the AV node. With increased vagal tone, conduction through the AV node slows down. Because the accessory pathway typically does not possess decremental conduction properties, it isn't slowed by vagal tone. A larger proportion of the ventricular myocardium is activated via the bypass tract. ECG shows PR interval shortens, the delta wave becomes more prominent, and the QRS complex broadens. With increased sympathetic tone, conduction through the AV node accelerates. The normal pathway wins the race to a larger portion of the ventricles. Result on the ECG, the PR interval lengthens, approaching normal, the delta wave shrinks, and the QRS complex narrows. Normal respiratory sinus arrhythmia is a common trigger for this effect, causing cyclic changes in vagal tone that perfectly correlate with the beat-to-beat expansion and narrowing of the QRS. While concertina effect itself is a benign physiological phenomenon reflecting normal autonomic fluctuations, its primary clinical importance lies in its ability to mimic other arrhythmias. It is crucial not to misdiagnose the varying QRS morphologies as frequent multiform premature ventricular complexes. PVCs will typically lack a P wave and have a compensatory pause, whereas the concertina effect maintains a 1:AV association with fluctuating PR intervals. Electrical alternance. Alternance affects the amplitude of the QRS due to shifting anatomical axis like a massive pericardial effusion, not the width of the QRS or the PR interval. Intermittent bundle branch block or aberrancy. Rate-related bundle branch blocks will abruptly widen the QRS when a critical cycle length is reached, rather than showing a sliding scale of morphological changes. In terms of risk stratification, a dynamic degree of pre-excitation, especially if it normalizes completely at higher sinus rates or during exercise, often suggests a relatively long refractory period of the accessory pathway. This is generally considered a lower risk feature for rapid conduction during atrial fibrillation, though formal electrophysiology study remains the gold standard for definitive risk assessment.